اتكلمنا عن الفيتال كاردياك ام ار اي.
Bismillah ar-Rahman ar-Rahim. First, thanks to Chairperson, Organizing Committee, for inviting me to share these hot topics in this valuable and prestigious conference. Maybe the title is more longer than it's appeared in schedule, because I want to not just to say to train you how to do a fetal cardiac MRI, not just to also we can compare the accuracy of it to diagnose congenital heart disease and comparing it with postnatal echo. Without doubt, the congenital heart disease is the most common congenital abnormality and first cause of infant mortality. Fetal echo, is still and will be, without doubt, it is a method of choice to visualize the fetal congenital cardiovascular abnormality. Also, the fetal echocardiography, its basic evaluation occurred in between 18 and 22 weeks, performed by 2D probe, color Doppler, and mode, and can add 3 or 4D modalities. And this to assess anatomy of atrium, ventricle, great vessel and their connections, blood flow, cardiothoracic ratio, cardiac axis, fetal heart rhythm, and myocardial performance index. However, there is some limitation of fetal echocardiography, like it's time consuming, maybe last up to 45 to 60 minutes. It's depend on the user, so it's technical skills and experience, and it's user dependable. Also, it has some limitation, either maternal or fetal limitation, like maternal obesity, uterine myoma, abdominal wall scar, or previous surgery in pelvis. Also, the fetal limitation like twins, oligo or polyhydramnios, abnormal fetal position, and rib calcification. Now we can start another modality can overcome the limitation of fetal echo, so we can express the advantage of fetal cardiac MRI over echocardiography. Fetal cardiac MRI, it can be done in each case of limited echocardiography, either maternal obesity, uterine myoma, twins, oligohydramnios, and abnormal fetal position. Also, it has additional information about fetal cardiac tumor, heart diverticulum, pericardial cyst, and pericardial effusion. And without doubt, MRI can detect any extra cardiac abnormality. Our aim of work is to highlight the advantage of MRI over fetal echocardiography in assessment of fetal congenital heart disease. Our study was in a cross-sectional study for 2 years durations. We are doing fetal cardiac MRI and fetal echo, and compared with postnatal echocardiography, it's done in radiology department at Ain Shams University with a partial source of cases in fetal care unit, either in Ain Shams University and Cairo University. We include all pregnant females suspected or diagnosed with fetal congenital cardiac abnormality by fetal echo during routine antenatal care, and excluding any case with maternal claustrophobia and any mother with cardiac valve replacement therapy or metallic implants. Our study including 52 pregnant females. There is no special preparation for a female for either fetal echo or fetal cardiac MRI, just detailed history for history of previous baby with congenital heart or family history, obstetric ultrasound and fetal echo, basic obstetric with all parameters, fetal echo including basic and detailed cardiac examination using B, mode, color, and pulsed Doppler. MRI was performed between 24 to 39 week gestation, with the mean was 30 weeks. The cases are the mother either lying in supine position or lateral decubitus. However, it's better to her because it will stay stable up to 45 minutes. MRI performed in 1.5 superconducting magnets, Tesla, and using a torso coil, phased array surface coil, abdominal coil. No maternal or fetal sedation has occurred. Controlled maternal breathing was used. What average time was ranged between 24 or 45 minutes. The imaging reviewing the imaging sequences of fetal cardiac MRI, starting with a survey, then getting a maternal plan in each position, sagittal, coronal, and axial for the maternal plans, and to assess the uterus and placenta. Then shifting into fetal body plan, axial, sagittal, and coronal in the single-shot fast spin echo with cardiac axis using a balanced single-shot fast spin echo for cine images. Black blood, white blood, dynamic sequences have added. Special tips that in each new acquisition is prescribed by using the immediately previous acquisition. So it's time consuming because it's any time the patients or fetus is moved or have an abnormal position. So it's, we are repeating the acquisition again. To avoid misregistration caused by fetal movement. Additional images can be obtained along the plane of brain or any suspected extracardiac region if they are suspecting it is a syndrome, syndromic. This image can highlight the steps taken in the fetal cardiac MRI, starting with an axial view, obtaining a mid-sagittal plane to get a pure sagittal or perfect sagittal plane, choosing aortic arch images from it, getting a coronal plane in which from apex of the left ventricle to the mid mitral valve, we can obtain from it a long axis view. From which the long axis we can have a perpendicular plane of it. We can getting a short axis, and from the short axis in the center of left ventricle and right ventricle we have get a perfect 4-chamber view, and from 4-chamber view we have get each side or each 2-chamber view, either right-sided 2-chamber view or left-sided 2-chamber view. MRI anatomy of fetal heart in axial plane. We can, in this level, we can get an interventricular septum is central. Cardiac axis is 45 degrees with both atrium and both ventricle have a complete comparable size, and great vessels and valve are occasionally seen. This is two comparable ultrasound, fetal echo, and fetal cardiac MRI. At the superior level and the left ventricular outflow tract, we can see a outflow tract of the left of the aorta, and right ventricular outflow tract. We can see a bifurcation of main pulmonary artery into right or left pulmonary artery, like we see in these below pictures. In 3-vessel view, show an aortic wind around the trachea, and as well as left brachiocephalic vein, which meets the right and which meets at the right in the right to form superior vena cava. In the coronal plane, MRI show cardiac abscess, left ventricle, cardiac apex, left ventricular outflow tracts, inflow systemic and its tributaries to the right atrium, either brachiocephalic to join superior vena cava, hepatic vein joining inferior vena cava, like we can see here the hepatic veins joining inferior vena cava into the right atrium, left ventricular outflow tracts and showing a left ventricle and aortic outflow. Also we can see here superior vena cava entering right atrium, and last view we can see a main bronchus, right bronchus and left main bronchus with hyperintense signal because it's filled with amniotic fluid. MRI anatomy in the sagittal plane, we can see a systemic inflow vein, also superior vena cava, inferior vena cava, which called a bicaval view, right ventricle and its outflow tract, right ventricular outflow tract and outlet of the main pulmonary artery, aortic arch and its branches. Challenging cardiac functional assessment sequence. It's challenging sequence, real. Although MRI and single-shot fast spin echo sequence is an established method for evaluation of cardiac function, imaging of obtaining beating heart in a moving fetus is more complicated. normal fetal heart between 120 and 160 beats per minute, and unpredictable fetal movement motion impair image quality owing to motion artifact during MRI. However, this trial of getting some information of functional records of fetal heart or fetal cardiac MRI, and it will be the next generation, the next our aim for detecting a functional abnormality by MRI. Also, this without doubt the real-time dynamic view. We can see end systole and end diastole in long axis and short axis, from which we can measure ejection fraction and cardiac output like we do in a cardiac MRI in pediatric and adults. Regarding interpretation of fetal echo, we're using a segmental approach, anatomical segmental approach, as we will know from next lectures. Yet, the image interpretation for fetal cardiac MRI is using a modified 10-step segmental approach, starting with vistioatrial situs, where is the stomach, where is IVC, where is the anatomical nomenclature of the left and right bronchus. Next, cardiac position, where is the apex, cardiac size, it may have to be 1/3, cardiac axis and the angle between the heart apex and mid-sagittal plane. Cardiac chambers, is it number 3, 4, or 5. Arrangement, size of the both atrium and ventricle, interventricular septums and valve. Next, going to the looping of the ventricle, either D or L loop, inflow vein, vena cava or systemic or pulmonary veins, outflow tracts, if it's getting the normal outflow tract for each corresponding ventricle or not. Like we do in next step, ventriculo-arterial concordance is in left ventricle getting aorta, and aorta getting an arch, which giving a next vessel or not. Right ventricle getting pulmonary artery, which is arching and bifurcating at distal end, and finding with the side of the aortic arch, mainly from bronchus above. For analysis of the axial section from inferior to superior part of the fetal chest, we're getting normal crossing of the origin of the great vessel with the main pulmonary artery crossing above the aortic root in a sagittal plane with an aortic arch mostly parallel to the left pulmonary artery. Our result getting a mean maternal age was 30 years, gestational age was 30 weeks, and gestational age at delivery was 36 weeks. The fetal biometry and umbilical artery Doppler was mean value was satisfactory. As regard fetal parameter, male gender was more prominent, presentation was cephalic, and amniotic fluid index was normal in most of 2/3 of them. Umbilical cord 3 vessel, and there is 1/3 of cases have intrauterine fetal death. Consanguinity was about half of cases, and previous history of anomaly was 30%, and high-risk disease was 11.5%. Regarding the agreement between postnatal and fetal cardiac MRI, was significant moderate agreement between the fetal echo and fetal MRI, and comparing individually with the disease individually, we're getting that the fetal echo have 86% agreement with postnatal in left hypoplastic and double outlet right ventricle. However, MRI getting 95.5% agreement between in many cases like VSD, ASD, AVSD, apparent cardiomegaly, TGA, right-sided, and pericardial effusion. And the rest of diseases, there are the same accuracy. Regarding extracardiac anomaly detected by fetal MRI, was many of them like talipes, like omphalocele, focal accretia of the placenta, grading of congenital hydronephrosis, anterior chest wall defect, like we can see in the illustrated cases. One of our cases was 20 years gestation, 20 years old with 25 years gestation, and everything was normal. However, previous anomaly, the baby has hydronephrosis, echo giving a pericardial effusion with relatively hypoplastic right ventricle, solitary VSD, measuring 3.5 millimeter and suspected mitral regurg. MRI getting similar some features and adding some feature. He getting the similar mild pericardial effusion, normal pulmonary venous drainage to the left atrium, and can see an additional apical muscular VSD. Incomparable with the postnatal echo, confirming the normal size right ventricle, mild pericardial effusion, and 2 muscular VSD, which is called a case of resolving myocarditis. The second case, the prominent things in it have a marked hydrocephalus and intrauterine fetal death with the previous baby. It's echo giving a cardiomegaly, tetralogy of Fallot, severe tricuspid regurg and absent ductus venosus, and absent venous drainage between umbilical vein and azygous vein. In MRI, giving developed severe hydrops, cardiomegaly, moderate pericardial effusion, and single large inlet VSD with common atrial trunk type 2, with side origin of hypoplastic pulmonary artery, and the key point was a prominent posterior azygous vein with compressed subdiaphragmatic umbilical vein draining into it. However, the baby was died intrauterine. Yet the tetralogy of Fallot is excluded, and it's we cannot confirm which of them is correct. However, the abnormal drainage of azygous vein was obvious in MRI. That case. Case 3, the patient was maybe normal with yet only the 2 vessel umbilical artery, echo giving complete unbalanced AVSD with hypoplastic left side, dilated main pulmonary artery and pulmonary regurg, tricuspid regurg, and aortic stenosis. MRI giving a cardiomegaly, hypoplastic left side, and large membranous VSD, overriding hypoplastic aorta, atretic mitral valve, thickened tricuspid valve, and normal pulmonary venous drainage. Postnatal echo confirming hypoplastic left heart syndrome and mitral valve atresia like MRI said. Case 4 was primary gravida, and giving echo with double dwarf versus hypoplastic left ventricle with large VSD, interrupted small aortic arch versus coarctation. It was query case in the echo. MRI confirming it is on hypoplastic left side with large VSD, hypoplastic aortic arch with interrupted aortic arch at the level of the left subclavian artery. And it is confirmed postnatally, it is hypoplastic left heart syndrome with type B interrupted aortic arch like MRI said. This last 2 cases were very interested case. This one is primary gravida with in vitro fertilization. MRI echo show mesocardia with ectopia cordis. Cardiac MRI revealed associated diaphragmatic hernia, anterior chest wall defect, left liver herniation through omphalocele, positional ectopia cordis. It is not true ectopia cordis. It is just positional ectopia cordis of left ventricle's apex. Small sized main pulmonary artery with left pulmonary artery agenesis and interatrial septal defect. Last case was 34 years old male, old female. Echo shows pulmonary hypoplasia, generalized hydrops with large, well-defined echogenic mass from left ventricle, and it either cardiac fibroma versus rhabdomyoma. Cardiac MRI revealed diagnosis of details of this mass size, origin with signal intensity and component and septation, confirming it is a rhabdomyoma with residual mitral valve side and bilateral hydrocele. We're skipping the discussion. We're leading to conclusion that an MRI imaging as an adjuvant to fetal echo may provide valuable information that could add the prenatal diagnosis and evaluation of cardiac and most of cardiac images. And this study was published 6 months ago. I hope this lecture gets your expectation. Thank you.
Thank you, Dr. Hend, for the amazing and promising approach to the fetal heart.